Hello everyone, my name is Louis Kreitmann and I'm from the medical ICU of Lyon University in France. This talk is about the use of a multiplex PCR assay to diagnose bacterial co-infections and guide antibiotic prescription in COVID-19 patients. I have received speaking fees from bioMérieux. Until recently, a major cause of ARDS related to a viral respiratory infection was influenza. And bacterial co-infections during influenza have well been documented. For instance, in this large prospective cohort study from Spain, the global prevalence of community-acquired bacterial co-infections was 17%, and it was increasing over time. And interestingly, bacterial co-infections are associated with an increased duration of mechanical ventilation and a decreased survival in the ICU. Now, what about COVID-19? When we started taking care of COVID-19 patients, we didn't know if they had bacterial co-infection and if we should treat them with antibiotics. So we turned to the guidelines. And the guidelines said, in critically ill COVID patients, you should use an empiric antibiotic therapy. But this was a weak recommendation based on low quality of evidence, because data on the prevalence of bacterial co-infection were limited. So we prescribed antibiotics to our patients, and we started a study to investigate acute bacterial co-infections at the onset of COVID-19 ARDS. And for that, we decided to use both culture and a multiplex PCR assay, the FilmArray pneumonia panel. Since then, several studies have been published on that topic. As you can see in this meta-analysis from Canada, 3.5% of patients are found to have bacterial co-infection at presentation, and around 15% to develop secondary bacterial co-infection. This contrasts with more than 2/3 of them receiving antibiotics during the course of the disease, which of course raised the question, can we use the MPCR for antibiotic stewardship in the care of COVID-19 patients? Now, when you look in detail at the studies, there is a huge heterogeneity in terms of study design, in terms of case mix. Some studies have looked at all COVID-19 patients in the hospitals. Others have focused on critically ill patients in the ICU. The inclusion period. A very important point is that some studies looked at community-acquired infections and others at healthcare-associated infections with, of course, a different microbiology. And finally, the microbiology workup itself has a huge variability in terms of the organs that are sampled, the pathogens that are looked for, and the techniques that are used. In our study, which was published as a letter in Intensive Care Medicine, we recruited 47 consecutive COVID-19 patients in 3 ICUs in Lyon. All patients were under invasive mechanical ventilation, and all fulfilled the Berlin criteria for ARDS. Because we wanted to focus on community-acquired bacterial co-infections, we sampled respiratory secretions in the 24 hours following intubation. As I said, we used a fully automated multiplex PCR test that gives semi-quantitative results for 15 culturable bacteria and qualitative results for viruses, atypical bacteria, and some resistance genes. All of that in about an hour. We found a rate of co-infection of 28%, with 3 dominant bacterial pathogens, Staph aureus, Haemophilus influenzae, and Streptococcus pneumoniae. You can see when you look in detail at the histogram that the numbers don't actually add up to 28%, and that's because 5 patients had more than 1 bacterial co-pathogen at the same time. Now, a second important study, the INHALE study, is a multi-center randomized trial that investigates the role of the MPCR in ICU patients suspected of having healthcare-associated pneumonia. The trial was paused due to the pandemic, but it was used to conduct a sub-study to characterize secondary bacterial infections in COVID-19 patients. As you can see, most samples were taken after at least 5 days in the hospital. The average rate of positive samples was around 50%, and the dominant pathogens were gram-negative bacteria and Staph aureus, which is not surprising given the timing of sampling. Now, the main concern for a physician willing to use the MPCR at the bedside is to know the concordance rate between the MPCR and standard culture. This question has been addressed in several studies, including one multi-center study that was used for the FDA approval process of the panel. And so here you have in green the positive percentage agreement or sensitivity, and in red the negative percentage agreement or specificity of the MPCR as compared to culture. And you can see that the concordance rate is very good, both in bronchoalveolar lavage and sputum, for all the pathogens that are on the panel. And that's the key point. Sensitivity and specificity are calculated separately for each pathogen, each target, and thus they cannot be calculated for bacterial species that are not on the panel. And in a sub-cohort of 259 samples from the same study, published in the second paper, bacterial cultures were positive for bacteria that are not on the panel in 11.6% of patients. And the list is here. As you can see, some of these bacteria clearly are known respiratory pathogens. The key message here is that under a high clinical suspicion, in the setting of healthcare-associated pneumonia, a negative panel does not rule out infection. That also means that we still need classical microbiology and the expertise of microbiologists. Now, what are the data in COVID-19? First, the INHALE study. In almost 2/3 of cases, there's a perfect agreement between PCR and culture. In 1/3, the PCR detects more bacteria than culture. And in only 3% of cases, culture detects viable bacteria that are on the panel, but they're not detected by PCR. So these guys are the true false negative. In our study, all patients with a negative culture had a negative PCR, and all patients with a positive culture had a positive PCR. So at the level of the patient, the concordance rate was 100%, but sometimes the MPCR detected more bugs. So in conclusion, there is a high concordance rate between the MPCR test and standard culture. But in about 30 to 40% of cases, the MPCR detects more bacteria. Why is that so? The first reason is that some patients may have received antibiotics before the test is done, making the PCR more sensitive. And a second reason is that it's possible that the PCR detects dead or non-viable bacteria. Another point is that, contrarily to culture, there are no validated thresholds of bacterial detection for the MPCR yet. And finally, neither culture nor the PCR can separate airway colonization from an actual respiratory infection, and this must be kept in mind when we look at studies that compare the MPCR to culture as the gold standard. And finally, a last point I wanted to address was the potential role of the MPCR for antibiotic stewardship in the ICU. This question was addressed in a Belgian study conducted in an ICU where all COVID patients had the MPCR. The first result is that 40% of patients have bacterial co-infection with your classical community-acquired pathogens, just like in our study. The second result is that in almost half of patients, the MPCR is used to guide antibiotic therapy, either to escalate or to de-escalate. And probably the most important point is that in this ICU, COVID patients are not usually started on antibiotics upon admission, but they have the MPCR test, and antibiotics are started only if the test is positive. This results in almost half of them not receiving a first-line empiric antibiotic therapy. The main limitation, of course, is that this study does not compare this strategy to standard of care. In that respect, there are at least 2 randomized trials that are ongoing to investigate the exact impact of the MPCR on antibiotic stewardship. These 2 trials are INEL from the UK, that I've previously mentioned, and Multicap from France. Both studies randomize patients to either standard of care with culture and the PCT from Multicap, or an arm where antibiotics are guided by the results of the MPCR, with outcomes including antibiotic usage and patient survival. And as for Multicap, there's a similar study run by the same group, specifically for COVID-19 patients, called Multicov. So we're very impatient to see the results of these 2 trials. Thank you very much.